Hello, everyone, and welcome to the World Thrombosis Day 2019 webinar, co-hosted today by the International Society on Thrombosis and Haemostasis, or ISTH, and by the Division of Blood Disorders at the Centers for Disease Control and Prevention, also known as the CDC. Today's webinar is titled Top 3 Considerations for the Prevention of Hospital-Associated Venous Thromboembolism. I'm Dr. Mary Cushman, and I'm delighted to be with you today. I am Professor of Medicine at the Lerner College of Medicine at the University of Vermont in the United States. And I also direct the Thrombosis and Haemostasis program at the University of Vermont Medical Center. I'm Editor-in-Chief of ISTH's Open Access Journal, Research and Practice in Thrombosis and Haemostasis. World Thrombosis Day is a year-long campaign that culminates annually on October 13th and focuses attention on the often overlooked and misunderstood condition of thrombosis, also called venous thromboembolism, or VTE. For today's webinar, I'm pleased to serve as the moderator. Yesterday, World Thrombosis Day hosted a global awareness event on Twitter, a Twitter chat, focused on learning the signs, symptoms, and risk factors for thrombosis. Ali Krieger, US soccer icon and World Cup champion, was the celebrity guest, and this brought in many new participants and patients who shared their personal stories, which were so wonderful to hear. Why don't we get started? It's my pleasure to introduce today's presenter, Dr. Jeffrey Weitz. Dr. Weitz is Professor of Medicine and Biochemistry and Biomedical Sciences at McMaster University Heart and Stroke Foundation and Executive Director of the Thrombosis and Atherosclerosis Research Institute in Canada. Dr. Weitz is a Fellow of the American Heart Association, the Royal Society of Canada, and the Canadian Academy of Health Sciences, and serves as a member of the World Thrombosis Day Steering Committee. Dr. Weitz joins us today to discuss the topic of hospital-associated venous thromboembolism. Dr. Weitz, thank you for being here. Let's begin.
It's my pleasure, Mary. And we're going to start with a number of poll questions. The first poll question is, which of the following best describes you? Healthcare provider, pharmacist, public health professional, consumer, community-based organization, industry partner, thrombosis patient, and/or survivor or other? Please address that question. The next poll question is, how did you hear about this webinar? World Thrombosis Day and/or ISTH website, CDC website, email, social media, referral, and/or word of mouth. Please answer poll question number 2. The third poll question is, which region of the world are you from? And we give you some choices. Please answer this poll question. Okay, let's get started. So the topic of my presentation is thromboprophylaxis in hospitalized patients. These are my disclosures, and I'll give you a moment to read them. The learning objectives for today are to provide you with greater awareness of the scope of the problem, to understand the determinants of risk, to offer a real-world approach to thromboprophylaxis, and to provide 3 top takeaways. So let's start with some facts about hospital-associated venous thromboembolism, or VTE. 1 in 4 deaths worldwide is due to thrombosis, abnormal blood clotting. Venous thromboembolism is the 3rd most common cause of vascular death after heart attack and stroke, and it's the number 1 cause of preventable death in hospitalized patients that's why we're focusing on hospital-associated VTE. 60% of all cases of venous thromboembolism occur during or within 3 months of a hospital stay. So this is a very important health problem. Venous thromboembolism encompasses deep vein thrombosis, a clot usually in the deep veins of the leg. Pieces of this clot can break off, travel through the bloodstream up into the lungs, where they lodge in the lung arteries to cause a pulmonary embolism. And a large pulmonary embolism can be fatal. We estimate that there are 10 million cases of venous thromboembolism and 600,000 deaths in Europe and in the US alone. This means with these number of cases and deaths per year, we have 1,600 deaths per day from venous thromboembolism. As I said, a major healthcare problem. A few years ago, the ISTH did a global survey to determine awareness of thrombosis compared with other major healthcare concerns. 85% of Americans say they know what a blood clot is, but only 27% say that they know of VTE, of venous thromboembolism, deep vein thrombosis, or pulmonary embolism. Now in Canada, we have various organizations that focus on venous thromboembolism, including some like Thrombosis Canada that are focused on increasing patient awareness. Despite these efforts, thrombosis awareness in Canada was low, with only about 25% of respondents knowing about thrombosis, and much lower awareness than that with common conditions like heart attack and AIDS and breast cancer. So we have a long way to go. And if you look at the bottom right here, the knowledge about risk factors for thrombosis also is low, with less than 50% of respondents realizing that surgery is a major trigger for venous thromboembolism in hospitalized patients, and less than a quarter of respondents knowing that hospitalization and cancer also are risk factors. So one of the purposes of World Thrombosis Day, as Mary said in her introduction, is to raise awareness about this condition so that you can advocate for assessment of VTE risk in high-risk situations and receive appropriate prophylaxis. Now, if we look at the numbers here, that hospitalization increases the risk of VTE about 10-fold. About 2% of medical patients develop VTE within 3 months of hospitalization, and up to 60% of patients who present with VTE have a history of recent hospitalization, and 75% of fatal pulmonary emboli, fatal clots to the lung, occur in the medical patient population. And as we said already, PE, pulmonary embolism, is the #1 cause of preventable death in hospitalized patients, and we want to reduce this toll. So if we think about risk determination, we need to think about risk factors, the relative risk with these risk factors, and the absolute increase in risk. Now, Rudolf Virchow, who was born on October 13th, which is why we celebrate World Thrombosis Day on that day each year, he identified three major categories as risk factors for venous thromboembolism. These include venous stasis or sluggish blood flow, vascular injury, damage to the vessel wall, and hypercoagulability of the blood. And together, these three factors conspire to increase the risk of venous thromboembolism. We said that surgery is a risk factor for venous thromboembolism. It increases the risk about 20-fold. Trauma increases about 13-fold. But hospitalization, even without recent surgery, increases the risk almost 10-fold. And cancer, with or without chemotherapy, increases the risk 5 to 7-fold. So knowing these risk factors can help us determine the individual risk for each patient who enters the hospital. For surgical patients and sometimes for medical patients, the Caprini risk assessment model is used. You see all these boxes. You check off the boxes that pertain to you. You add up the score, and the more boxes that are ticked, the higher the risk, and the more you need thromboprophylaxis. We know from meta-analyses of trials comparing prophylaxis to no prophylaxis that providing prophylaxis reduces the risk of symptomatic and fatal pulmonary embolism in medical patients by about 60%. This means that the number of patients needed to treat to prevent, with prophylaxis, to prevent one venous thromboembolic event, and let's take the worst case scenario, one fatal pulmonary embolism, is 400. Now that might seem like a lot, but if we put that into perspective and think about mammography to prevent breast cancer death, data would suggest that the number of women needed to screen in the age group of 50 to 69 years is 721, and the number needed to screen in those 70 to 74 years of age is 451, very similar to the 400 that we saw for VTE prophylaxis. So these numbers to treat are very reasonable, and what we're trying to do here is to prevent fatal pulmonary embolism. Now, why are hospitalized medical patients at highest risk? And the reason for this is that there's so many risk factors that can add up in the medical patients, because the medical patients today are getting older, they have multiple comorbidities, and many of these things like older age or cancer or immobility or lung disease or acute inflammatory disease, all of these are risk factors for VTE. So we need to think VTE in patients who come into the hospital, and everybody, patients alike, should be advocating for VTE risk assessment, and for those at risk, they should get thromboprophylaxis. Let me just go back one. So at rest or at risk, be aware, be proactive, prophylax. Someone in bed, immobilized, with maybe only bathroom privileges, with medical conditions, they're at risk. They should get prophylaxis. So let's have poll question number 4. If you are a healthcare provider, do patients admitted to your hospital undergo VTE risk assessment? Answer yes, no, or I don't know. So a first attempt at thromboprophylaxis in the medically ill was to just give everyone entering the hospital thromboprophylaxis with an anticoagulant. The problem with this approach is that the rate of VTE can vary widely across the unselected medically ill populations, and thromboprophylaxis with low doses of heparin does not necessarily confirm the same risk reduction in all patient groups. So without individualizing this, you may not reduce VTE and you can increase the risk of bleeding. So we have to select patients who are at the highest risk of this condition. And in the 9th edition of the American College of Chest Physician Guidelines, they recommended an individualized approach to risk assessment using patient risk factors to determine the appropriate thromboprophylactic strategy. The ISTH World Thrombosis Day Steering Committee provided a call to action for global VTE risk assessment, and effective January 1st, 2017, the Centers for Medicare and Medical Services, CMS, mandated VTE risk assessment. So mandated VTE risk assessment is now coming to the fore in many hospitals and in many countries. In Canada, VTE risk assessment is mandated, and ensuring that it happens is part of quality assessment for hospitals, and hospital accreditation depends on hospitals demonstrating that they have an effective VTE risk assessment program in place. Here are 7 simple steps to improve DVT prophylaxis in your hospital. The hospital needs to be committed to this, and you need to have a champion for VTE risk assessment and for implementation of thromboprophylaxis. There needs to be a written policy on thromboprophylaxis that's simple and standard and indicates who gets prophylaxis and with what. Pre-printed order sets, computerized order entry, and decision support keys can help, but the prophylaxis decision has to be mandatory and everyone should be involved. Physicians, nurses, pharmacists, and patients. And you have to audit the results of your prophylaxis program and improve, and continue auditing and improving. So the ideal risk assessment model enables accurate identification of patients who meet a threshold risk for DVT in the absence of prophylaxis. It should exclude patients who are at high risk for bleeding. It should be evidence-based and validated and simple to use. Patients and caregivers must be aware of VTE and have a risk assessment checklist. Some risk assessment models, such as the Padua model, use a scoring system. You add up the score, and the higher the score, the higher the risk of VTE. The improved VTE risk assessment model is another model used to assess risk. And again, you add up the score, the higher the score, the higher the risk. That's shown here in the validation of this model, that overall patients, the rate of symptomatic VTE in the overall medical patient population is only 1%. But if you focus on patients with an improved score of 3 or higher, the 3-month rate of VTE is about 3% for symptomatic VTE overall, and about 1.5% for symptomatic PE. So by focusing in on the patients with a score of 3 or more, these are the patients that should be targeted for thromboprophylaxis. Now, high-risk patients routinely get thromboprophylaxis while they're in hospital. As you know, hospital stays are shortening. Patients remain at risk even when they go home. What do we know about extending prophylaxis beyond the hospital stay? And unfortunately, the data here are somewhat conflicting. We still don't have optimal methods for identifying patients at high enough risk for out-of-hospital VTE to identify those who should receive extended prophylaxis. So both the American College of Chest Physicians and the American Society of Hematology in their most recent guidelines recommend against routine extended prophylaxis in medical patients beyond the hospital stay, but they recommend prophylaxis for these patients while in hospital. So I said I would give you 3 key takeaways, and the 3 key considerations for prevention of hospital-associated VTE. Patients and healthcare professionals need to have a clear understanding of the risk factors, the signs and the symptoms of VTE. We need to identify high-risk patients and deliver appropriate thromboprophylaxis to hospitalized patients to reduce the burden of hospital-associated VTE. And to identify the patients at risk, VTE risk assessment should be assessed in all hospitalized patients worldwide. So empower patients and empower yourselves and get involved in World Thrombosis Day. I'll stop there. I'll turn it over to you, Mary, and we'd be happy to take any questions.
Thanks so much, Jeff. That was really a clear and very helpful presentation. So I would encourage people who are listening to type your questions into the left-hand side of the webinar interface, and we'll be happy to discuss them. And maybe I can start, Jeff, with a question around the World Thrombosis Day. What would you say is the easiest way for a healthcare provider to get involved with World Thrombosis Day, and why would they want to do that?
Well, all they need to do is join our World Thrombosis Day group. It's very easy. You can do that online. There's all kinds of information available there that can be of use if you're a healthcare provider, and provides tremendous information if you're a patient. So know the facts, know your risk, and advocate for prophylaxis.
Great. So I want to thank everyone for starting to send in questions. So I will start drawing from the questions from the audience, and please do keep the questions coming. The first question I'd like to ask is what you feel are the remaining high priority challenges to providing optimal prophylaxis in hospitalized patients.
Well, I think that the main challenge is still to assessing risk and determining which patients should get prophylaxis and which patients should not, and then delivering the prophylaxis, the appropriate prophylaxis to the patients who are at risk. So it's a multi-step process. It starts with risk assessment. The risk assessment tool has to be simple, has to be uniformly applied, and you have to weed out the low-risk patients or the patients who are at high risk for bleeding. If they're at high risk, but also at high risk for VTE and also at high risk for bleeding, then you have to use alternative methods like mechanical methods. So you have to have a algorithm, a pathway of care to manage prophylaxis. I think we have good prophylactic agents that are fairly easy to use, but they have to be given, and they have to be given to the appropriate patient.
Yeah, I think that's the crux of the problem, Jeff. We have a research program here in our group that's trying to get at this issue, and there really aren't, from the bleeding risk perspective, we don't have customized tools, say, for example, for medical inpatients. I think for surgical patients, we sort of understand the bleeding risk for different kinds of surgeries,
easy.
But trying to figure out, do you have ideas about, for those who are listening, who are managing hospital systems for medical patients, what could you suggest in terms of thinking about assessing bleeding risk in these patients so you can balance the two?
Yeah, we don't have very good tools for assessing bleeding risk, and that's a disadvantage. But certainly patients who have thrombocytopenia, so that might be in our cancer population, or patients who have come in with some bleeding, these are the patients that can be problematic because they can still be at risk for thrombosis, but we know that they're going to be at risk for bleeding. But you're right, Mary, we don't have really good tools to assess bleeding risk.
Do you have a particular risk assessment model that you think is easiest to apply for hospital assessment or for the medical patients? How do you do it at McMaster?
Well, we have sort of a modified scoring system that uses a hybrid of both the Padua risk factors and the improved risk factors. We do not do biomarkers like D-dimer as part of our risk assessment. Yeah, it's a really, I think that is what I would agree with. And it seems to me the most important thing is to actually take a moment to assess the risk. The other thing we've been thinking a lot about is how do you assess the risk over time during the hospital stay? When a person gets admitted, they might be low risk and then develop factors during the hospital stay, complications or what have you, that lead to an increased risk. Yes. And I think people often, you have to make sure you're paying attention to that on patient transfers or when their status changes. Yeah, I must say that our go-to anticoagulant for prophylaxis is low molecular weight heparin. We rarely use unfractionated heparin. And our trigger for prophylaxis is, the bar for prescribing prophylaxis is fairly low. So a large percentage of our medical patients do get prophylaxis. It's a really great point you raise about the selection of which drug to use. The American Society of Hematology guideline that was published in 2018 addressed this question and came up with different recommendations compared to other guidelines. I think now we have 6 different guidelines from around the world from different places on how to prevent VTE in hospitalized medical patients. And the ASH guideline published last year suggested low molecular weight heparin over unfractionated heparin. And I think as a participant in that guideline, I think that was very important. Do you have thoughts about that? Why would you pick that compared to unfractionated heparin? The reason we select low molecular weight heparin is for patient comfort. It involves only 1 injection a day instead of 2. For patient safety, the risk of heparin-induced thrombocytopenia is considerably lower with low molecular weight heparin than with unfractionated heparin. So that means we don't need to monitor the platelet count as closely with low molecular weight heparin as we do with unfractionated heparin. So those are some of the reasons why we have moved to low molecular weight heparin. Yeah, those were pretty much the considerations we brought forward in the ASH guideline. And for safety too, Mary, we in our hospital, we use low molecular weight heparin in pre-filled syringes so that the nurses aren't drawing up from a multi-dose vial with a high concentration. So dosing errors are also really reduced because if you're giving 5,000 units of unfractionated heparin twice a day or 3 times a day, and you're drawing up, you could make a dosing error. So it reduces dosing errors as well. So lots of good reasons to use low molecular weight heparin.
That's a really great point. I still see in our hospital patients receiving heparin 3 times a day. And it just seems like almost an inhumane thing to do to a person when they're critically
they just
ill.
don't like that. And then what they start doing is they start refusing the injections. And then you're not doing them any favors.
Yeah, there's actually a great line of work out of Johns Hopkins University looking at this issue of patients declining their injections in the hospital. And they have this great program that sort of if a person declines their injection, the team swoops in and gives them education to make sure they understand why it's being prescribed. And they've shown that is effective in improving. So these kinds of implementation science research studies are really important because it's not just knowing what to do, it's making sure that it actually happens. And they really track the compliance. And I think that's another piece of it that practitioners don't often think about.
Right.
So I have another question. What do you use for prophylaxis when a person is felt to be at increased bleeding risk?
Well, if I really think that the bleeding risk is too high to use chemical prophylaxis with an anticoagulant, then we use intermittent pneumatic compression, what we call moon boots. They squeeze the leg and they, on up and down, and that squeezes the blood out of the legs and improves blood flow and removes one of the 3 causes of VTE, according to Virchow's Triad, which is sluggish blood flow or stasis. And also the squeezing of the legs induces the release of the natural clot digesting substance, tissue plasminogen activator. That might also account for some of the way it works. There was a very interesting study done a number of years ago that showed that putting these compression devices onto the arms could reduce the risk of clots in the legs.
Yeah, that's a great point. I often teach the residents that point when we're talking about prophylaxis on the wards. And are you aware of any data on effectiveness of putting them on the arms if the legs are unavailable, like if a person is an amputee? Or
there was only one small study of that, and I think it would be a thought, but there's not enough to really know the utility of that approach.
Another question has come in, sort of a related question, and I see this a lot in my own hospital at the University of Vermont Medical Center. What would be the benefit of combining pharmacologic and mechanical prophylaxis? Can you comment on when you would use both together?
Yeah, if I can use chemical prophylaxis, I tend not to use mechanical prophylaxis because I think overall the chemical prophylaxis gives you very good thromboprophylaxis, and you don't need to do the mechanical prophylaxis. And the problem with mechanical prophylaxis is that it's cumbersome because it only works when you have it turned on. And if a patient has the device on, they can't be up and mobilizing. So it can slow mobilization. And often I go into a patient's room where mechanical prophylaxis has been ordered, and I see the device there, but it's not turned on, and I go in and turn it on. So I think that, stick to chemical prophylaxis if you can, and then if you can't, then think about mechanical prophylaxis. And I rarely would give the two in combination.
Yeah, I wondered about that as well, mainly based on my personal experience in our own hospital. And for the American Society of Hematology guideline, we addressed this question very thoroughly for those who might be interested. I think it was Dr. Wood who asked this question. And we really could not find any literature supportive of the concept of doing it. I think maybe it makes us feel better in those highest risk patients that we're doing everything we can. But
right.
But when you think
and the
about
other thing is that the other thing, Mary, is that we've gone through several different generations of mechanical compression devices, and what happens is you order it, and then the nurses are scrambling to try and find the stockings and the pump unit that are compatible, and we're scrambling all over the hospital to piece together the system. So unless each ward has dedicated devices, it can be difficult to do it. So again, whenever possible, use chemical prophylaxis, and really reserve mechanical prophylaxis to the patients who are at high risk for bleeding. So,
Jeff, could you comment on the differences in terms of approach to from surgery patients to medical patients? There's a question about this. How do you handle the risk assessment for surgery patients compared to medical patients?
Well, I think as you mentioned earlier, it's much easier in the surgical patients because you know what surgical procedure they're going to undergo. You know whether it's going to be an outpatient procedure and they're going home later that day, or whether they're going to stay in after the hospital. And so you can use a more proscribed prophylaxis regimen. Typically, we will again use low molecular weight heparin starting after the surgery, as soon after the surgery as we can, depending on when hemostasis has been achieved. And, depending on the type of surgery, if it's surgery for cancer, we might prescribe a month of prophylaxis. If it's surgery for a lesser condition, we might prescribe prophylaxis just for the duration of the hospital stay or until the patient is mobile. And of course, for the orthopedic surgery patients, our standard of care used to be the use of a direct oral anticoagulant starting the day after the surgery, given for 2 weeks in the knee replacement patients and for a month in the hip replacement patients. And then after the EPCAT, the Canadian EPCAT study, the sort of standard risk orthopedic patients now get 5 days of a direct oral anticoagulant starting the day after surgery, and then they get a month of aspirin. And the EPCAT-3 will be comparing that regimen with aspirin right from the get-go.
Yeah, it's really this long-standing question, isn't it? And it seems like this secular trend over the past couple of decades has been for less aggressive approaches in that population. Do you have thoughts on why that is?
I think that the surgery is getting better, less invasive. The risk of VTE is going down, so that now, the risk of symptomatic VTE at a month is probably only in the range of about 1%. Or 2% at most. So it's a low risk, so you don't have to be quite as aggressive about prophylaxis as we did in the past.
Yeah, I totally agree.
And that's true for a lot of surgical procedures. But if the patient has cancer, for example, if they've got, a pathological fracture, or if they're getting surgery for cancer, I still think these patients are at higher risk, and they should probably get chemical prophylaxis for a month at least.
Yeah, that's a great point. Here's a good question from a patient. And thank you for the patients who are on this webinar. I hope this is helpful for you as well as it is for the clinical people on the call. So as a patient, if I'm being hospitalized, what are some of the questions I should ask my healthcare provider as part of a VTE risk assessment?
Well, as a patient, you should know your own risk. So risk factors, have you had a prior episode of venous thromboembolism? Is there a family history of venous thromboembolism? Do you have underlying cancer? All of those would be significant risk factors that you should tell the doctor about, and then you should be advocating for prophylaxis. If you have no risk factors, then you should be saying to the doctor, look, you're telling me I need to be hospitalized, and how long do you think I'm going to be in? Do you think I have a risk of venous thromboembolism? And if so, should I get some prophylaxis? And ask for information. But know your risk. And it's pretty easy to assess that. And there's information on the World Thrombosis Day site that you can download, and you can kind of assess your own risk with simple tools.
Yeah, that's a great point. I think if people aren't familiar with the World Thrombosis Day website, they should become familiar with it. Both, really any stakeholder who's on this webinar. We have public health professionals, we have industry employees, we have pharmacists, patients, community-based organizations. And what I suggest to my own patients is when they're on social media to follow World Thrombosis Day on whatever channel they're on, whether it's Twitter or Facebook, Instagram, that these small pieces of education come across your feed on a pretty regular basis, 365 days a year. It's not just during World Thrombosis Day week or month or what have you. So I think having those reminders is helpful for patients. Okay, I have another question. What are the thromboprophylaxis options for pediatric patients?
Yeah, that's a great question. I don't deal with the pediatric patient population, but for the older members of the pediatric population, the low molecular weight heparin is a go-to agent, just like it is for adults. For younger pediatric patients, low molecular weight heparin is still an option with appropriate dosing.
Yeah, and I think that topic is covered. I'm not 100% sure if it's covered in the American Society of Hematology guideline on pediatric thrombosis that came out in 2018. I think that the literature is probably really thin in terms of what should be used and who should be used.
Right. In general, the risk of VTE is lower in children and adolescents than it is in sort of those who are in their late teens or early 20s, partly because of different levels of inhibitors. So the levels of one inhibitor of blood clotting, so-called alpha-2 macroglobulin, are actually twice that of adult levels in the pediatric population, which provides some protection. But nonetheless, the very, very young, the prematures, it's often the catheters that are used to get into the bloodstream and trigger clotting. And we really don't have very good ways to prevent that. So there's same is true for adults who have central venous catheters for blood delivery for drug delivery, like chemotherapy delivery or antibiotic delivery. We don't have good methods to prevent that. And research that's ongoing is looking at new drugs that might be better than what we have now to prevent device-associated clotting.
Yeah, it's a really important area for study. Can we make the device itself safer, or is there another medication can be used?
Right. Well, we've had lots of years to make safer devices, and we really still have got the same problem. So I think we'll have to do more than just looking at coatings or different biomaterials.
What we've learned in our research here in terms of the catheter-related thrombosis in hospitalized adults, medical patients, that the size of the catheter, the number of lumens is really important, and which vein it's placed in. So I think the more space that the catheter takes up in the vein, the higher the risk, basically. So
I see one other interesting question there. Someone's asking, well, should patients be screened for thrombophilia before they go into a hospital so that higher risk patients can be identified? And the answer to that question, it's a good and interesting question, but the answer to that question is no, and let me explain why. Because the odds ratio, or the increase in risk for the common thrombophilias, if you have them, your risk of VTE might be increased twofold or maybe threefold. But as I showed you, going into hospital and having surgery increases your risk about 20-fold. And if you're a medical patient with multiple medical illnesses, increases your risk about 10-fold. So these increases in risk outweigh the increase associated with thrombophilia completely. So whether you have thrombophilia or not, you should be getting prophylaxis if you're at high risk. And testing for thrombophilia really is, not that important. Now, if you know you have thrombophilia, then your risk is higher, and for sure that would be one of the things that, as a patient, you should be telling your doctor, look, I have the factor V Leiden mutation, and there's a family history, or I've had a previous VTE. Those should be triggers to get prophylaxis.
Great discussion. So here's another interesting question. Is there data demonstrating reduction of fatal pulmonary embolism with prophylaxis?
Yeah, the meta-analysis I showed you does show a reduction in fatal pulmonary embolism. And that was the number needed to treat at 400 was based on that 2007 meta-analysis. You'd have to treat 400 medical patients with prophylaxis. To the next slide after that, to prevent one fatal PE. You see, so to prevent a symptomatic PE that's fatal and non-fatal, 345, to prevent a symptomatic DVT, 196. But I circled the fatal PE because that's what we want to avoid. But don't neglect even the symptomatic deep vein thrombosis, because deep vein thrombosis, especially extensive deep vein thrombosis, can lead to long-term sequelae like post-thrombotic syndrome, and we want to avoid patients to have to deal with something like that for the rest of their life.
Yeah.
But yes, I mean, the whole idea is to prevent death, but we're also preventing other morbidities that can occur even with non-fatal PE or with deep vein thrombosis.
Right. So here's a related question. I see a lot of patients who really have psychological distress following thrombosis. And here's a question that came in. Today is World Mental Health Day. Can you quickly address how a healthcare provider should address this side of the diagnosis?
Yeah, I think that's really important. And there, you referred to what we call kind of post-PE syndrome. Patients have a pulmonary embolism, and they may have pleuritic chest pain, pain when they take a deep breath. They may have shortness of breath, and they may have a feeling of impending doom or anxiety. And these symptoms are so overwhelming and so fearful that they don't want to ever have them again. So they're afraid to have another pulmonary embolism. And after they get treated, it can take some time for their symptoms to go away. So you have to support the patients, tell them that, yes, of course, you've read this is a potentially fatal disease, but the most important thing is that either we give the prophylaxis to prevent it in the first place, but if it does occur, that we make the diagnosis and we give the appropriate treatment. Because once patients get the appropriate treatment, the risk of death is markedly reduced.
Yeah, and I think part of the reason for these problems that patients experience after the diagnosis is that they didn't know in the first place what VTE was, or that it even exists, or that they were at risk. And then they get this life-threatening event that they had never even heard of. And I think that's why, World Thrombosis Day activities are so important to raising awareness,
Right.
because that can help patients cope better if it does happen to them.
Right. And we've talked a lot, Mary, about the risk factors for VTE, but we haven't talked much about knowing the symptoms of deep vein thrombosis and signs of deep vein thrombosis and pulmonary embolism. And it's important for people to know those symptoms and signs so that even if they get prophylaxis in hospital and they then go home, if they get those symptoms or signs, they should suspect that they may have deep vein thrombosis or pulmonary embolism, get immediate medical attention, get the diagnosis ruled in or ruled out. So it's
Absolutely.
important to know your risk factors and know the symptoms and signs of VTE.
Absolutely. There was some good discussion of that on the Twitter chat yesterday. And, I hand out the World Thrombosis Day sort of infographic to everyone. And this is something that should be given to patients when they're going home from the hospital, for example.
Absolutely. I don't think we do enough of that, Mary. So, now we've talked about mandating VTE risk assessment, getting prophylaxis, but also provide patients with information when they go home about what to look for after they go. So somebody asked, well, where do we stand on extended prophylaxis for the medically ill? And unfortunately, we still don't know how to identify the highest risk patients who deserve extended prophylaxis. But if we're not going to give it, then for sure we need to give them that sort of information sheet so that they know what to look for and they can come back and get get assessed. The same thing is true for cancer patients who are getting chemotherapy and maybe biologic treatment with biologics. They're at risk, so they need to know their risk and they need to know the symptoms and signs so that should they develop, they can come early for diagnosis. I see so many cancer patients who've been having progressive pain and swelling of a leg, for example, over a number of weeks. And they just said, well, it must be part of my cancer. And then they find out that they have DVT. And if they had known that that's one of the things to watch for, I'm sure they would have come earlier.
Absolutely. There was a great tool shown on the Twitter chat yesterday by Thrombosis Canada. And it's a little card, like a pocket card handout, with these 5 red circles vertically with the word clots, CLOTS in
Right.
each circle. And next to it, C is for chest pain, L is for lightheadedness, O is for out of breath, T is for leg tenderness, S is for swelling. And it says at the top, if you have any signs, and at the bottom it says, go see a doctor right away. Very simple. And we need
yes,
simple
and
tools.
That came from Agnes Lee in Vancouver, who's great at finding acronyms for your clinical trials. She always comes up with good ones, but that was one from her that Thrombosis Canada has adopted.
I'll have to keep her in mind to help the next time we start a new study. We need a name for it.
Yeah,
okay.
Think about that.
Yeah. So I have a question about, we'll have one final very quick question. Can you discuss women's specific risks, including pregnancy or oral contraceptives in the hospital? Is there a different prophylaxis method for women in this case?
Yeah. So of course, pregnancy and post-pregnancy is a risk period. But again, I'm not saying that for healthy women, it's not so much of a problem. But I think the use of oral contraceptives, or even more importantly, the use of hormonal replacement therapy, is something to know about, because the older women taking hormonal replacement therapy, if I know that they're taking hormonal replacement therapy, my bar for recommending thromboprophylaxis is lower. And if If it's an orthopedic patient, for example, I'm probably going to go for a month in those patients rather than just a couple of weeks or, some truncated period, because again, I realize that that's a higher risk factor.
Yeah,
and
totally.
The postpartum period, if they're hospitalized, they should get prophylaxis.
Totally agree. And, in the setting of these exposures, especially patients with obesity, because it's also a risk factor, or really if they have any additional risk factors. Okay, so it's unfortunately time to start wrapping things up. We'd like to thank Dr. Weitz for this important presentation, and we really hope that you all have found it useful. Following the presentation, you'll receive a recording of the webinar in 1 or 2 business days, and we invite you to celebrate World Thrombosis Day this Sunday, October 13th. You can do this by going online or by participating in an event in your local community. And if there isn't one, maybe next year you could plan one in your local community. Visit www.worldthrombosisday.org to learn more about this global awareness campaign and how you can get involved. Thank you for participating, and we appreciate your support of World Thrombosis Day and this activity.